of anesthesia in trauma, a discipline where precision meets critical decision-making under pressure. We will explore the intricate relationship of trauma and the lung, delivering effective pain relief in trauma, providing safe and tailored anesthesia care for elderly trauma patients, and the challenges of intensive care management, highlighting the strategies that optimize outcomes and enhance patient recovery.
And to guide us through this important topic, it is an honor to have with us two distinguished chairpersons. We would warmly like to invite Dr. Sandhya Somavira, consultant anesthetist at National Hospital of Sri Lanka, and Dr. P. Murugadas, consultant surgeon at National Hospital of Sri Lanka.
Good morning, everybody. We warmly welcome all of you for the session on anesthesia in trauma. I have the pleasure in associating with anesthetists here, with whom we usually associate in the theater. And we were told during the training program, there are two individuals with whom a surgeon should not fight. One is wife and one is anesthetist. And both will make your life hell at their respective places, right? So there we are. So our first speaker is Dr. Malin Gunawardena, consultant anesthetist at National Hospital of Sri Lanka, Colombo. I had the great pleasure in working with Malin in Kalutara Hospital. We were there for nearly 3-4 years, and he will speak on trauma and the lung. Over to you, Malin.
Good morning, and thank you for that introduction. I hope I don't make life hell for you. Right, so thank you very much for the invitation to speak here on, and I will speak on trauma and the lung, because in the ICU we see patients with so many respiratory problems that it is very, very common, and it's something that takes a lot of our time, and it involves a lot of morbidity and mortality. So I thought we'll speak about it a little bit. So just the overview, and be an introduction, causes of respiratory injury, care outside of ICU, and I'll spend a little bit of time on that, especially for the junior staff who are here, because that is a very important thing to minimize the respiratory effects of trauma, and also a little bit on the future of management of respiratory disorders. So why trauma and the lung? So we have both direct and indirect injuries, extrathoracic injuries that can lead to respiratory distress. And frequently it is easy for us to identify the direct injuries, but many of the injuries we see may not be identified initially. So there may be many injuries that we don't really see on the first presentation, but we come across these later on in the wards and in ICUs. Right? So respiratory distress is common. It frequently increases the stay in hospital and therefore the resources that we have to spend on these patients. So just a little bit about the last 16 days in our ICU at National Hospital Sri Lanka. So this is ICU with 10 beds, right? And we cater to patients who come directly to the National Hospital of Sri Lanka, and also many patients who are transferred from other units for specialized tertiary care. So if you take numbers, you see that there are almost 75% of these patients have some sort of respiratory injury. So some of these respiratory injuries, maybe at the outset, they come with maybe direct respiratory trauma, but a lot of them are actually not related to the first direct injury. So they come across later, and sometimes we identify them in the ward, sometimes in the ICU. So you can see out of them actually 50% are not direct respiratory injuries that we have identified at the outset. Okay, so what about the direct lung injuries? Right? So these are easy to identify. They are blunt or penetrating trauma, contusions and rib fracture. So these things we identify either from our EFAST or when we do our initial X-rays or CT scans, we identify these early. But there are many respiratory problems that occur following the initial presentation. Right? I have listed some of them, and you might see that some of them are actually not that easy to identify, and they come across with the same sort of presentations, which is basically a patient who has shortness of breath. So in these situations, we had to actually think of these possibilities when we are treating them. So some of them are actually related to trauma, such as fat embolism with long bone injuries. Some of them are associated with the therapy that we actually give these patients. So it may be transfusion-related lung injury, right? Or some of them may be simply because of the prolonged period of stay in hospital and immobilization. So deep vein thrombosis, frequently poor nutrition that leads to many problems afterwards. These are all problems that we might have in these patients. I have mentioned spinal cord injury separately, and it is something that is commonly seen in our ICU, in the wards and in our ICUs. So we have a lot of falls from heights, right? Some of them are, many of them are following patients who climb trees, maybe to pluck fruits and coconuts, right? And some of them are actually related to the wonderful habits we have on the roads. So we are not great at following road rules. So these result in a lot of trauma. I must say that I was not happy, but I was surprised that Thailand has a difficulty in implementing the helmet in people who are driving, because I think we have been successful in that. The majority of our riders actually use the helmet, but we still do see a lot of trauma. So spinal cord injuries, especially the cervical spinal cord injuries and the high thoracic injuries, frequently involve respiratory problems, and these guys usually spend a long time in ICU, taking a lot of our resources. So ICU management is, of course, multidisciplinary. It's easy for us in the ICU because we have the staff, we have one-to-one nursing, we have the respiratory physicians helping us out, we have the microbiologists helping us out, the physiotherapy, which is coming in and out of ICUs. So for us, it is easy. And of course, the surgical colleagues who sometimes might have to fix ribs or do a wax procedure. So in ICU, managing these respiratory problems is not too difficult. So it may be from simple oxygen therapy to invasive ventilation to surgical procedures which are necessary. And of course, these patients spend a long time in ICU and do take a long time in getting better. There are a lot of challenges in the wards, and that's what I would actually like to speak on for a short while. Right? Delay in identification frequently because the numbers are very high in our wards. Our wards are full of trauma patients, and our staff, they are very, very good, but with the numbers, it's sometimes difficult to identify problems early. So lack of adequate monitoring, we've improved our monitoring during the last few years, but still there is always room for further improvement. Frequently these patients suddenly deteriorate and there is no critical care input at the time in the ward, so these people sometimes take a little bit of more effort to be improved, right? And we do need an HDU in all our hospitals. Unfortunately, we don't have a high dependency unit, so there is a lot of strain on the ICU to manage these patients. Early warning systems play a big role in improving identification of these patients, and we've been able to, the Ministry of Health has introduced a national early warning score, which has helped many of our wards to identify early deteriorating patients. Unfortunately, we've had a few hiccups in implementing this in the trauma setting, but hopefully we'll be able to do that in the near future. But the concept of early warning scores have actually gone to the staff, and we see very much fewer patients coming in acute distress needing major input from the ICU because they've already had something done in the wards. Right, so this is our early warning score. It's a common early warning score that is there in all hospitals, I think all places throughout the world. So the initial one would be the monitoring, and the next would be the response to what you find. I'll just like to spend a little time on the respiratory rate as an early clue, because this shows A and B, and the respiratory rate is so very important in identifying patients who are deteriorating in their lung function. So you can see the scoring, right? I'm sure you all are, a lot of them are familiar with the scoring system. So we identify these patients very early by an increased respiratory rate. It may not, of course, be respiratory, it may be some other problem, but obviously somebody who breathes fast is very ill. The other thing I want to highlight here is the fact that oxygen itself scores something. So giving a patient oxygen means that the patient needs oxygen. That's something that we have to get into our minds. So if a patient needs oxygen, this scoring system is very good because it scores something for giving oxygen too. So these are critically ill patients who might actually deteriorate further if we don't take necessary steps. So that's another important part in the early warning score that we need to stress. The oxygen fallacy, it's not rocket science, but it's something that we always try to remind our juniors. Right? When you're on oxygen, you have to be a little careful when you're interpreting saturations and blood gases. As you can see on this slide, a normal alveolar ventilation will give you a saturation of 100. This is of course partial pressure, but it will give you a saturation of 100. But the moment you put oxygen on the patient, you need not breathe that well, or your lungs need not be that good, but still you will have a saturation of 100. So this is something that we really need to keep in mind when we are monitoring patients in the ward. There are a lot of factors that worsen the respiratory complications in patients with trauma. Frequent comorbidities, these are guys who we have not really seen before, and they may be having many comorbidities that are affecting their outcome. Substance use, unfortunately, is growing in Sri Lanka, and I'm sure it's growing around the world. And many of these young people who come with trauma are substance abusers, or they use substance. And because of the need for ventilation, for sedation, for pain relief, it takes a lot of time to actually get these patients out of ICU, and sometimes it takes a lot of effort, even in the wards, to manage these patients. So this is a big problem for all of us. Right? Other things I have mentioned, like lack of mobility, inability to commence DVT prophylaxis because they have bleeding somewhere else. All these factors play a big role in making respiratory complications just a little bit more difficult to manage. And poor nutrition also is a factor that we have to keep in mind, especially when we have theatre lists which are very, very crowded, so we can't accommodate all patients in our theatres. These patients continuously go through periods of fasting, and their nutrition becomes very poor. So if they've been in hospital for a long time, their nutrition is inadequate to actually overcome the problems that they have. Preventive strategies in ICU, once again easy, right? Frequent chest physiotherapy, position changes and mobilization, which we do frequently. Lung expansion strategies, we have the NIV, meticulous fluid balance, which is very important, right? All these things, DVT prophylaxis, prevention of sepsis. And here, another thing I have not mentioned, but which my colleague is going to speak to you about optimal pain relief in trauma. These are all factors that make it easy for us to actually manage patients in the ICU. But what about the wards? Because the wards are the ones we manage maybe 10 patients in the ICU, but it's the ward that has the majority of the patients. So what about the things we can do in the ward? Whatever we do, we should be able to work as a team, and we do. In our hospital, we do work as a team, although the numbers of patients are very, very large. We do have a teamwork, and of recent, we have had outcomes which are very much better than we had some years ago. So early mobilization and ambulation, once again, following early surgery is something that we can try and do. Effective pain control, we have outreach teams that work from the ICU, and our pain consultant will say there are pain teams that go around. So all this can be used to improve the respiratory component that is adding to the trauma of the patient. Right? Incentive spirometry and deep breathing exercises, which would be possible in wards, right? And the others, as you can see, physiotherapy, changing of position, DVT prophylaxis, all these factors are things that we can actually use in the ward to prevent or to minimize the problems occurring in the respiratory system. We do have high-risk patients, and something that we would like to have in the National Hospital of Sri Lanka, which is the premier trauma center in Sri Lanka. So a high-risk, HDU is an ideal place for us to actually optimize patients or to treat patients who might be of higher risk, and also to send our ICU patients out to the HDU rather than to a normal ward. So it's something that we lack, but we need to work on in our hospitals. Right? So looking ahead, what can we do? Infrastructure development is very important, right? And training of our staff, be it the junior staff, the senior staff, in managing patients. So we have ongoing programs in the National Hospital where we have maybe CPR programs, ABCDE related programs. So we have these programs ongoing to train our staff in managing critically ill patients. Right? And increasing human resources, of course, is very important because, as I said, the numbers in our hospitals are very large. And if you go to our main ward that we have, our main Ward 72, I think most of us must be knowing Ward 72, it's a hive of activity from morning till night. So the more people there are to manage these patients, the more quickly we can actually identify patients who are critically ill and need a little bit more care. So another thing that is important is audit that we need to do. We need to audit what we are doing, because what we have been doing is actually improving our management of patients in our hospitals, especially identifying patients early who are deteriorating so that we can minimize the complications. But audit and the audit process will actually help us see where we are going and how we are improving. So in summary, respiratory complications are very, very common in trauma. Early detection can be achieved with teamwork and a trained staff working in an optimal environment, and early management can definitely lessen the burden on ICU and reduce healthcare expenditure. So the message would be that patients with respiratory problems can be managed in ICU, but actually preventive measures are best done within the ward setting, and this will result in a very much better outcome for most of our patients. Thank you.
Thank you, Malin, for the excellent presentation. I think we can have the question session at the end of all 4 lectures.
Okay. Let me introduce our next speaker, my friend and colleague, Dr. Ranmali Kulasiri. She is the senior consultant anesthetist at National Hospital, Sri Lanka, and she is well experienced in primary trauma care as well as trauma critical care. And she is going to talk on trauma anesthesia in elderly. Yeah, over to you, Ranmali.
Thank you. Thank you, Madam Chairperson, for that kind introduction. And my topic today is trauma anesthesia in the elderly. So we call it the silver trauma. Why? Because these patients are more than 60 or 65 years. They are not detected early when they are admitted to IC or to the tier hospital, and inadequate resuscitation has happened, and it has not been it has been shown that the patients have not been transferred early to a primary trauma care setting where they would have got the optimal management and would have improved their morbidity and mortality. So why is the anesthesia in the elderly with trauma different? So we as anesthetists, we like to see them preoperatively, optimize them after assessment, and then we anesthetize. So I'm going to go according to that format. So what are the preoperative considerations? They are a bit different from our normal thing. Now we see these patients at different stages. They are transferred directly from the resuscitation bed, most probably not resuscitated adequately, or from the ICU after some sort of initial resuscitation has been done, or from the trauma ward after the secondary and tertiary survey with missed injuries. So we see a spectrum of patients from the most stable one or a relatively stable one to the unstable patient. So what are these preoperative considerations? So when we see a patient, we must see what is the mechanism of fall. They might just say, we just slipped and fell from the bed or from a chair. But you have to remember, they will have very serious injuries like lateral compression fractures, head injury, rib fractures, pelvic fracture. So they have major injuries. Then there are the effects of aging. There's the reduced physiological reversal in all bodies, and there's the decreased ability to compensate because of their age and their obtunded sympathetic response. On top of that, there's dementia, hearing impairment, and health issues, other mental health issues, which will make us find it very difficult to take a history on top of all these other problems of trauma. Then don't forget abuse. They have substance abuse, and on top of that, there can be elder abuse, which is quite commonly seen now. Then it has been shown there are 5 pre-existing conditions which significantly influence the outcome, like cirrhosis, coagulopathy, chronic obstructive pulmonary disease, ischemic heart disease, and diabetes. We all know that these really influence the outcome, but we have to significantly see in this age group. The next thing is frailty. I will not go into any detail because this was dealt very well yesterday. We have to assess the clinical frailty scale because frailty per se is a parameter which causes a bad outcome in the patients. So there are many frailty scores which you can use and assess. And then we have the problem of the fasting. Some are over-fasted in the wards, they have not had anything to drink or eat for some time, or they are unfasted, full stomach patients which will come to our theatres. Still, we have to anesthetize all these patients. Then most of these patients are on direct oral anticoagulant drugs taken orally or the vitamin K antagonists like warfarin. So we have to use the local protocols to reverse it as necessary or ask our hematology colleagues. I just added tranexamic acid because most patients are on has been given tranexamic acid when we come to the theatre. So according to the CRASH 2, they had shown there is a significant improvement if you give of controlling the bleeding, if you give it early, but no age is specifically mentioned. So is CRASH 3, which was done for head injury, and they showed there is some survival benefit in the mild to moderate traumatic brain injury. Again, it was done in patients more than 16 years, nothing mentioned about the old age group. So I have no idea about it. Then we come to the assessment. Again, I think I can skip this because it was there before. So we go as CABCD or XABCDE. So first thing is to stop the exsanguination, stop the bleeding. What we do is compression or apply a tourniquet just above the injury. Then we go into the airway, what we are really worried about and what we have to do. So the dentures, remember the elderly will have dentures with them. This will get dislodged and dentures per se can obstruct the airway and make it a difficult airway. And we have to, but it helps in a way because it gives a good seal for pre-oxygenation and ventilation. So at the time of intubation, you need to remove the dentures to intubate, and again that might make a difficult intubation. Cervical spine. So most patients might have a cervical cord. Now the new recommendation is you have to exclude a cervical spine injury as soon as possible. You can do the C-spine, Canadian C-spine, or the nexus criteria can be used, or clinically if there is any pain over it, any scratch, if the patient is ambulatory, whether the patient can move his limbs. If so, you have to remove that cervical spine collar. Because cervical collar per se can cause confusion, restlessness, pain, difficult intubation and pressure sores. So it's advised to remove it as soon as possible. And you must remember, 50% of the cervical spines are unstable. And geriatric trauma patients undergoing a head CT for trauma should have a cervical spine imaging done. So as at NHS, if we go in for whole body CT, we get a pan spine done to exclude the cervical injuries. Next is the breathing. So even a small trivial fall will cause rib fractures. Not one, they have multiple rib fractures with flail segments, which gives rise to lung contusion, pneumothoraces, hemothoraces, cardiac tamponade, all that. So we should have a lower threshold to intubate this patient. If there's respiratory distress, dropping the saturation, we have to get a CT or an EFAST done to exclude injuries, and we will intubate this patient. Then comes to the circulation. As previously mentioned, we have to stop the circulation, and we have to remember that early symptoms of shock is difficult to identify in these patients because they have chronic diseases which will impair the autonomic response, and there's decreased physiological reserves in the body, and they might be on medications, especially beta blockers, which will not show a rise in the heart rate, and because their blood pressures are high, we will just accept the blood pressure which is there as normal. So how are you going to assess? Clinical assessment is the best. If the patient is confused, restless, complaining of difficulty in breathing, these are all signs of shock. So we have to remember this, clinical signs. And then we can elicit certain things. Capillary refilling time, more than 2 to 3 seconds is shock. Heart rate of 90 or above, systolic blood pressure of 110. In the young, we take it as 100 or even 80. Now it's 110 in this elderly age group. And respiratory rate less than 10 or more than 30. And age adjusted shock index. We know shock index is age divided by heart rate, which is heart rate divided by systolic blood pressure, which is about 0.5 to 0.7 normally. But these elderly, we have the age-adjusted shock index, and if it's more than 50, we have to assume it's shock. And the next thing is the arterial blood gases, serial blood gases. If the lactate is more than 2, base excess of -6, that shows the patient is in shock. So we need to resuscitate this patient. So how are you going to do the damage controlled resuscitation? The aim is to provide adequate blood flow to all the organs to supply the oxygen and the nutrients. And it is the hypotensive resuscitation is basically contraindicated. These patients, the organs are is used to having a high blood pressure, and we need to maintain that blood pressure for organ perfusion. They are most often dehydrated. They are not eating and drinking. They might be on furosemide or any diuretics. So the new recommendation is to give 250 or 500 ml of normal saline before anesthesia or even before blood products are given, because they are dehydrated. And in this age group, we cannot give large volumes of blood because we can push them into heart failure. So sometimes we might have to use vasopressors like noradrenaline. Again, we need to tailor it because too much of noradrenaline will push them into heart failure with vasoconstriction. So a senior involvement is necessary, and we need to balance with their fluid and your vasopressors and go in for surgery as soon as possible to stop this bleeding. When we go in for blood, we go as 1:1:1, and if the massive hemorrhage protocol is being activated, we get the boxes and we can go ahead according to that. So what are the targets? Clinically, patient will improve, the heart rate will come down, the capillary perfusion will reduce, patient might start producing urine, and we can do the rotum regularly and the serial blood gases to see if the lactate and base excess have come down. But lactate will take a while to come down, so we have to continue our resuscitation. So before we go into control of bleeding, we will do the D, assess the AAVPU or the GCS, and expose and see other injuries and prevent the hypothermia which can happen. So the most important thing is the control of bleeding. So it is the damage control surgery where we come in. We have to anesthetize this patient, this sick patient. And then our lives have been revolutionized with this damage control radiology, which is very helpful in liver lacerations, spleen, pelvic injuries, which are done at the National Hospital, and it has made our lives very, very easy. But we have to remember, might have to anesthetize this patient at any time. So how are we going to provide the anesthesia? You have to remember certain things. Whatever you give, you have to resuscitate this patient to some extent before we start. Senior involvement is absolutely necessary, anesthetists and the surgeons. And we must anticipate decompensation, because all the anesthetic drugs we give will cause myocardial suppression and vasodilatation. So the blood pressures are going to crash. And invasive monitoring is important, especially an art line, but we should not stop surgery just to enter the art line, because we can do it later. And all this to do to restore end organ perfusion. So what are the problems? How are we going to overcome? We need a good wide bore cannula. 16, 17 or 14 two wide bore cannulas in 2 different places. We have to have the difficult airway trolley close by, video laryngoscope and bougie. And you have to assume that every patient has a cervical injury and put manual inline stabilization. And your supportive staff should be very good and help you out with all these problems. So there are the 3 hard rules and the 3 soft indications for intubation. So mainly we think of if there's airway failure with and ventilatory failure, carbon dioxide going up, and if the patient is unconscious, GCS is dropping, we need to intubate. The others are soft. Actually we have to think about whether we are going to intubate this patient. So you need to have multidisciplinary approach or talk with your surgeon and decide. So your induction, we have to pre-oxygenate them well. There's lung contusion. They can be having pneumothoraces. Their FRC is low, so we need to pre-oxygenate them well. And whatever drugs we give, we have to titrate. I cannot give you a dose. We have to titrate it to the patient. So we normally give fentanyl 1 mic per kg. Induction dose with ketamine will be good because propofol can cause myocardial suppression and vasodilatation and bring down the blood pressure again, and rocuronium for intubation. So in our part of the country, we use suxamethonium and we continue to use it now. So maintenance, we do not give inhalational agents. It will just deteriorate the patient again. So we need to give morphine, small doses, and fentanyl. You can go up to 20 mics per kg during surgery. And you have to continue to do your fluid resuscitation. Analgesia, I'm not going to touch because my colleague is going to take all about it. We can give IV paracetamol. Please do not withhold opioids. Sometimes you do not give opioids, it makes me go crazy. Patient needs opioids, they are in a lot of pain. And we can go in for regional techniques depending on the stability of the patient. So where are we going? Up to where are we going to resuscitate this patient? We have to check with everyone. Just see if the patient has any advance directive. The family should be informed early. Discuss with them. Tell about the patient, actually his condition, and they can decide. We cannot actually be told and say this is end of life care. You have to be educated. And we need to get early family involvement. Early involvement of the palliative and rehabilitation physicians and take their ideas and treat this patient. So in summary, trauma in the elderly is different from other cohorts. It is all due to aging, the physiological reserves are poor, and their medical issues. Mortality and morbidity is quite high in this group, so we have to look after them properly. And they need to be transferred to a major trauma center where CT, ICU is available. Active resuscitation should be done initially, but we have to first assess the patient whether this patient is actually ready for transfer or for surgery, because we have a spectrum of diseases. And advanced life directives should be taken into consideration. These are my references. And I want to thank all the trauma patients who have been admitted to the trauma unit and to our ICUs, because they have given us a lot of experience and confidence to work with it. And I want to thank all the anesthetists who work 24 hours at the National Hospital, the ICU medical officers and the trauma surgeons, the radiologists, the physiotherapists and the nursing officers, because they do a great job. And I want to thank my now they are senior registrars who helped me to make this presentation. Thank you.
Thank you, Ranmali, for that very informative presentation.
We'll get on to the next lecture. And I have the pleasure in introducing Dr. Prasadini Karunarathne, the currently consultant in neuroanesthesia, National Hospital of Sri Lanka, Colombo. And previously she held the post of consultant in charge of pain medicine at National Hospital. I had the pleasure of working with Prasadini at Anuradhapura Teaching Hospital when I started my career as a consultant, and she was the junior anesthetist at Teaching Hospital Anuradhapura over 25 years ago. So over to Prasadini.
Thank you for the kind introduction, and it's a great privilege to address this trauma symposium. Thank you for that as well. So I'm going to talk about how pain should be managed in trauma patients. You know, pain is unpleasant sensory and emotional experience with or without tissue damage. But pain in trauma is more than that, because it's an unexpected event to the person's life with lot of fear, anxiety, fear of death, fear of losing a limb. So those things also will add to the physical trauma. So most of the time we see patients with severe, in severe pain conditions. So it's not only a physiological event, it actually affects you psychologically, it affects it socially, and can lead to a very unpleasant situation like chronic pain. So all these unwanted effects you can manage to a certain extent with proper acute pain management. So yeah, as we see, I think all of you know the pain pathway, which contains multiple neurons, ascending and descending tracts, with lot of receptors and neurotransmitters. So if you address all these points in your pain management, then your pain relief will be more efficient rather than giving one single drug. So this is very important to keep it in mind throughout in your pain management. So the most important thing in the management is the assessment. Even the WHO has recommended pain is the 5th vital sign you should monitor in each and every patient. And use a proper assessment scale is also important because pain is very subjective. It may be vary when you are in even the same patient, if you assess by 2 people, it could be vary. So always use a validated tool because it will help to decide what is the treatment option that we are going to offer to the patient, and for the reassessment of the patient to see whether we have given an effective intervention, and to communicate as well. And also, sometimes patients not be able to communicate, especially trauma patients, either due to trauma or due to substance abuses or any other reason. So therefore, there are tools for those patients as well. And as you know, the trauma patients are in all ages, even small child who is not be able to talk or communicate at any means. So even those patients, even a neonate, we have to assess with a validated tool. And you know, the nociceptive pain or trauma pain is a protective mechanism as well, right? So only relieving pain is not an answer, especially in trauma. So you have to re-evaluate to whether you have missed any other injury. So reassessment and re-evaluation is very important in pain management. And you know that you have multidimensional tools, but in trauma situations, initially we use unidimensional scales like numerical scale, visual scale, or defense and veterans rating scale, whatever you are familiar and easy to use. But in pediatric patients also, we have different scales. And in the ICU patients or cognitive impaired patients, we have used behavioral pain scales or critical care pain observation tool, you know, CPOT, and you have to use whatever the validated tool you are used to use in your units. If you talk about management, it's not only pharmacological, you have to use non-pharmacological measures as well, because patients, you know that patient's psychological condition, right? So those things should be addressed as well. If you talk about non-pharmacological measures, I think the nursing staff, and not only the nursing staff, actually each and everyone has a role there. You think that is non-pharmacological only for the physiotherapist or somebody? No, it's each and every person. Because when you talk to the patient, reassure the patient, right? Show empathy, talk, and that also help to reduce pain to some extent. So from the beginning of the patient's entry to the hospital, that non-pharmacological measures works if you think about that as well. And splinting or immobilize the injury, those things also helpful. Raise the limb or sometimes cold fermentation, those things matters much. Pharmacologically, you can use pharmacological agents and regional techniques as well. So you know the WHO pain ladder, step 1, 2, 3, depend on your pain assessment, the severity score. But in trauma patient, we usually follow the reverse ladder because most of the time our patients are in severe pain category, that is pain score around 10, 7, 8, 9 or 10. And the drugs usually we have to use parenteral route and multimodal analgesics. So these are some drugs including simple analgesics, NSAIDs and adjuvant agents and opioids as well. So there's a big place for opioids in trauma pain management. And NMDA receptors also we are using at the initial stage because it has sympathomimetic effect, and you know that patients are sometimes very hypertensive, so you cannot use drugs like opioids because it can cause further vasodilatation and drop in blood pressure. So regional techniques we are using very frequently nowadays in National Hospital. So it will help to reduce your pharmacological agent dose and as well as can be performed without making much instability of the patient. There are problems when you are performing a regional block, but most of the time peripheral nerve blocks can be performed most of the patients. So there are some challenges we are facing. One thing is that patient may have coagulopathy. Sometimes we don't know about the history. Patient is unconscious. We don't know any clinical record. We don't know whether patient is on any anticoagulant or antiplatelet. Still, if we are as we are using ultrasound and especially the peripheral nerve blocks, we might be able to perform, but you have to weigh the risk and benefit at all instances. And when you are performing a block, you should know whether it is indicated to this patient, whether that pain area is covered with that block, and see whether there's contraindication as well, and there's adequate resuscitation facilities. Think about the local anesthetic toxicity, or calculate the dose, and should be able to done by a person who is used to that and who has experience as well. And antiplatelets and anticoagulants, if you know about the history, you can see whether when was the last doses given, and when can you perform the block without making any problem to the patient. If you cannot identify, we better avoid that rather than doing more harm to the patient. Especially in neuraxial blocks, it can cause further damage to the patient, further complication to the patient by dropping the blood pressures or forming epidural hematomas. But nowadays, paravertebral blocks, sometimes erector spinae blocks, will cover the affected area without going to epidurals. So there's a lot of alternatives today which will be more helpful and more safer to perform without going to neuraxial access. What is multimodal analgesia is that we are using all sorts of methods together for the pain management. It is, as I said earlier, The pain pathway, you know, it has so many relays, so many neurotransmitters and receptors. So if you block these, most of the places with drugs, regional blocks, and with non-pharmacological measures, the pain relief is more. So always try to use multimodal analgesia. One thing is the effects are better, other thing is unwanted side effects are less because you are using less amount of opioids or NSAID in those patients. And patient also should be able to accept reasonable degree of pain, that we cannot alleviate pain to zero score. So we have to tell the patient, we can reduce your pain up to some extent, but you will have pain when you have movements or when you are doing some procedures. But that doesn't mean that patient has to suffer, but patient should be informed or patient should be explained, and patient must have some sort of expectation that I cannot think or I cannot ask for a 0 pain score. But this usage of multimodal analgesia will help to reduce it to a minimum level. So what we talk about pain relief is pain score is less than 3 with movements, and or patient is comfortable, patient says I'm comfortable. Because our target is to have a good pain relief when the patient is in active state, not in the resting stage. So in the trauma care continuum, we have to use all sort of strong agents at the initial stage, but we can reduce or de-escalate once the pain has settled and with some time, some days passed. So always escalate depend on the pain score, and de-escalate depends on the pain score as well. So pain relief should be start from pre-hospital setting actually, which is not very much practical in our country, but ideally it should be done. So analgesic doses like agents like ketamine will help in that case because it will not affect your hemodynamic instability, and respiratory is not a big problem. Not anesthetic dose, but the analgesic dose like 0.25 to 0.5 milligram per kg can be used even pre-hospital care. But all the patients should be adequately monitored, even it doesn't affect your respiration, but the patient should be monitored. And in the emergency department where you have much more facilities, more experienced people and more agents, an ultrasound scan machine and all sorts of drugs. So try to perform a nerve block then and there. And sometimes patients with opioid usage, substance abuse in drugs, who are more prone to get trauma as well, will come as patients. So it doesn't mean that patients should not get any opioid. They should get more opioids because they are not NIVI patients. And in the perioperative period, during the surgery and immediate post-operative period, again, you have to give a maximum pain relief because the maximum intensity of pain is at that point. And there are problems. One thing is AKI, rhabdomyolysis, and hypovolemic, so a lot of pre-renal impacts. Maybe patient CKD, we don't know, and coagulation disorders or coagulopathy at that point. So these things will be challenges, are the challenges in pain management as well. Avoid NSAIDs and try to manage with opioids in these situations. And if you have a patient-controlled analgesia pump, we are waiting to get some more to the National Hospital actually. Fentanyl or morphine is another option. Then if the patient is conscious enough and can use his or her hand, it is a good option. And in the intensive care as well, so we can use the same agents because the one-to-one patient care. So give maximum pain relief during the ICU stay, because if you do not manage initial severe pain properly, the patient can lead to a lot of psychological impacts like post-traumatic stress syndromes or chronic pain conditions. And when your patient is transferred to the ward, try to convert it to oral route, because then the ward nurses can manage easily, and convert to enteral route and prescribe the proper dose of drug using opioid conversions or whatever resource you are having. And so we get patients, and when you're discharging as well, the patient should get adequate analgesics. Sometimes you forgot to prescribe any antibiotic. We see some patients coming to the pain clinic without any analgesic given when they are discharging. So please consider that and don't forget to prescribe as well. And at the end of, if you decided the patients cannot be survived, talk with the family, and even at the end of life care, even though you stopped antibiotics or anything, give the maximum pain control as well. And give a good environment, sorry, can I go back? The good environmental facilities, proper place, whether they can use rituals or they are religious things, those things also you should provide on those patients. And some of the older patients we are getting as trauma patients, always remember that they can have a lot of other medications, and they are more sensitive to pain as well as for the drugs. So carefully decide the dose and selecting the drugs as well. Sometimes drug interactions, and NSAIDs especially, be careful when you are prescribing. Pediatric patients, again, use a proper scale as well as per kg dose is essential when you are managing. Regional blocks sometimes not be very easy because they are awake unless they are under anesthesia, but try to perform when they are going for a surgery. Per kg dose is essential when you are giving doses. And they can have opioids, and they should be given opioids as well. And pregnant mothers, non-pharmacological measures or even opioids you can use even at any trimester. Use it properly with adequate monitoring. And in patients with substance abuse, also, as I said earlier, they should get more opioids than other normal persons. But de-escalate your management just before they discharge from the hospital. Oxycodone is a drug that we don't have at the NHSL, but if you have it, it is very good that we can use it rather than morphine in our wards. That's why I used only that drug as an individual agent. So if you have it, it is less respiratory depression. So oxynorm or oxycodone is a very good drug if we can have to use in the wards. And PCA analgesia as well. It's because patients control his or her own analgesia, so it will be very helpful rather than giving a lot of oral drugs. Sometimes you will undertreat it, or sometimes you will overtreat the pain. So if we can have PCA pumps, it is much more easier. Right, few take-home messages. Assessment, reassessment, and re-evaluation is very important, and pain management is always individualized. So you have to select depending on the patient. Short-acting opioids, NMDA receptor antagonists are very effective in the initial stage, and regional techniques usage of non-pharmacological techniques also essential, and always show empathy when you are managing patients. Thank you.
Thank you, Prasadini, for the very informative lecture.
Okay. Our last speaker is Professor Reuben Peralta. He's a Deputy Trauma Medical Director and Senior Consultant and Director of the Trauma Surgical Critical Care Fellowship at Hamad Medical Corporation, Kota. He's going to talk on challenges in ICU care. Has anything changed? Over to you, Professor Peralta.
Good morning, thank you. It's a great pleasure to be here, to be in beautiful Singapore. I have a lot of reasons for what. I become really friend to Dr. Kirte and the organizing committee, but I have a product of my life here. It's Dr. Faith Ahmed Ramsey. He was a fellow of us, and now he's becoming a star. He's becoming an international star, but I just want to ask him if he can come with me to his country to provide all of his great example of progression and to help the people of Sri Lanka. So we'll talk about this during the day. Just going to talk today about changes, what changes has happening in the ICU probably in the last 10 or 20 years. I have no disclosure or passion for education, and as you can see, I cannot do anything alone. It takes a team, it takes a village, it takes a nation to become really good in what we do. This is Qatar 101. It's an enclave in the Persian Gulf. It's a small country with a lot of expats, probably 90% of the population, and it's becoming a metropolitan city, Doha, during the daytime and during the nighttime also. Hamad Medical Corporation provides around 90% to 95% of the care of the citizens of Qatar. And we established the Hamad Trauma Center. It's a state-of-the-art trauma center. It was established in 2007, and approximately 400-bed trauma and emergency center. A report is being certified by the Canadian authorities since 2014, and it's really report to the National Trauma Data Bank, also to all the quality international benchmark. And as you can see here, this is what it looks like a discotheque, a club at night, but it's really, really busy. And the question for this talk is, has anything changed in the last 10 to 20 years? And I think a lot, just in the last 10 years, we have an incredible pandemic that changed all of these parameters that we practice. We were afraid, we didn't know too much about things. And if you group and your ICU telling you that you have to do a tracheostomy in 10 days or 7 days, when the COVID, nobody asked about the question. We were doing tracheostomy 3 weeks, maybe 4 weeks, and the results is different because I told my students and my residents and myself that, what we practice is an art, it's a lot of passion, and it's really minimal, it's a small percentage of science on it, because everybody is different, and if we will follow protocol, but every patient has a lot of comorbidities that we don't know, especially in trauma. And we have impact in the last 10 years of incredible conflicts, armed conflicts that have destroyed all of us, including this country, especially now Ukraine, Russia. Also, the silent war, the silent armed conflict that nobody talk about. For example, for us, Sudan. I have 4 fellows right now from Sudan. And this is really, I'm becoming a psychologist for those people because, they really complain about what happened to their parents. Sometimes there's no internet, the communication is blocked. They have to take day off. Sometimes there's no agency to send money to them. So this is an incredible thing that is going on in the world. And then close to my heart, I have the Haiti conflict. It's a civil war managed by a gentleman called Barbecue. Could you imagine when a gentleman called barbecue and he's really managing the country? It's something that is really alarming to all of us, okay? Now United Nations is there, we don't know what's gonna happen. And then this happened, this Israel-Gaza. You know, I'm being blessed that the authorities in Qatar, the Emir, the king, has assigned 2 fellows from Palestine to us. But I'm telling you, I'm becoming more than a psychologist. One patient last year, and one of my Dr. S last year, his family has to transfer 21 times from Gaza, 21 times in 1 year. From the north to the south, to the south, to the north. So it's incredible, and they are our colleagues. And beside that, on top of that, we have 250 Gaza patients in our hospital. So he was, I have to give it a counseling and say, you are not a representative of the patient. You just have here to learn, because he got too attached to them that was really impairing a clinical knowledge, even the foundation of delivery care to those patients. Then the objective to that list, I'm going to ask you to your attention to see how the technology is changing the ICU, changing the trauma patients monitoring. How we should not forget about the family-oriented care that we should give in the diverse population. The point of care testing is here with us, the multidisciplinary care, and really we have to be prepared for the other pandemic or the other conflict around this area. I have to tell you the big data is really important. As you can see, we have Dr. Fay here rotating when he was a fellow with us now is a specialist. He's one of the best promising stars that we have. And you know, we as electronic medical record, we really base all of this compository data, doesn't matter who you use, we should be using our trauma register. We are happy in Qatar that we have developed the Qatar National Trauma Register that any hospital, doesn't matter if it's civilian or military, is really the repository is our trauma register. And because we have a lot of resources, we are lucky to benchmark to the American College of Surgeons, the National Trauma Data Bank, and the TQIP. The TQIP is the Trauma Quality Improvement Program. And this has been established as a benchmark to 535 trauma centers in the United States. And I'm happy to report to you that we have the best performing of all the trauma centers in the United States is in Qatar. It's not in the United States. And as you can see, this is the report from March, the last report, 2025, when we are in 1 decile percentile. Our percentile is vary between 1 to 2% of all the trauma centers. This is an incredible and remarkable thing that I think is being based by compassion and education, because we have universal health care. Everybody's treated the same, from the royals to the low socioeconomic class that we can, for us, they are the same, and they are treated with the dignity and compassion of our trauma center. So this is what a patient and family take a lot of important, because our population is diverse, like probably the population of Sri Lanka. Multiple nationalities, multiple religions, and multiple languages. And I'm going to bring you the first case. This is a 27-year-old construction worker or work-related injury that a bulldozer went through his body. That was his mechanism of injury. He fell asleep, and his driver gave a reverse and went through the pelvis, and as you can see, he produced an incredible open pelvis fracture. And he became in shock, and then, as you can see, was completely bleeding, and then we have to really provide care to this patient. This patient came out with a huge perineal wound, actively bleeding, and as you can see, many of those patients now that we didn't know 20 years ago, they come with severe coagulopathy. This is one of the new concepts that has been changed in the last a few years, a few decades. We established a damage control resuscitation that you probably heard before. Stop the bleeding is the number one, or try to stop the bleeding. And non-compressible hemorrhage, sometimes it's difficult that you have to bring a technology like Riboa. And also, we have to really increase the resuscitation product. Instead of using normal saline or crystalloid, we have to use blood and blood balance. We had to do permissive hypertension if you don't have a severe traumatic brain injury, and we had to use adjuvant. What we have done in our trauma centers, we have constructed in an advanced algorithm and protocol where we start with the blind resuscitation, as you can see there. And now we have changed from 1 gram of tranexamin, now we use 2 grams of tranexamin. And we use POCT to guide us our resuscitation after the second treatment. Because we have money, and a lot of money and resources, we have now a rotten and tech platelet mapping. And the reason is because in many of those patients, one of the components of this deranged coagulopathy is they have a platelet dysfunction syndrome. This is a patient that is bleeding to death. You know now.
Because anti-medication,
and this is not to scare to everybody, but you have to have a massive transfusion protocol, something game changes if you have an acute care hospital. Doesn't matter if you have OBGYN service, all of us, we may have to use and activate the massive transfusion protocol. And this massive transfusion protocol has been, gravitated and has been advanced with a lot of component and adjuvant as we really progress in the implementation science of utilization of emergency blood. And we have really published about that, about the trauma resuscitation of, with massive transfusion. A descriptive analysis if time is important or what is the ratio that is important. In our study, in our over thousands of patients, we know that timing is really important. We have to control the bleeding and trying to address and mitigate this coagulopathy. And 4 hours is our key point to increase your survival rate in our hospital. If you wait 12 hours to give all the products and control your coagulopathy, your mortality increase significantly. Can provide control of the bleeding, resuscitation, and endovascular approach to those patients. And then we go back to the coagulopathy. Coagulopathy can be produced only for the severe injury, but also for severe uncertain injury, especially traumatic brain injury. And we use both conventional tests to provide coagulopathy. And I just reviewed a paper last week about coagulopathy. Yeah, some camps say that coagulopathy is INR greater than 1.2. For us, some camps is greater than 1.5. Let's have an example, this is 1.5. But we have to use the POCT in those patients to make sure that you really correct those. And we have published about the coagulopathy in surgical patients and our experience from our group. And now we know that the early identification, timing, correction of coagulopathy is really correlated with stop the bleeding quickly and provide the blood product that those patients need. And we have to gravitate, this is another change. From the lethal triad, we usually limit that terminology and we call now the lethal diamond or the lethal rhomboid. Because calcium is an incredible element in this diamond that really can address this coagulation derangement that we see in those patients. And also, calcium is important for the coagulopathy. Calcium is important for the factors to work. Calcium, is really important when you have an acidosis, you know, the deviation of the calcium. So right now we don't use a lethal triad. If you see in many presentation and report, we use lethal diamond. And another issue is when you get those blood products, those blood products have citrate on it. Citrate chelate your calcium, and your calcium goes low. And that's how we really make sure that viscoelastic static, a great guidance to use that is the European guidelines, or you can use to do that. This was maybe 10, 15 years ago. We used to have this is the Tech 5000, and our fellows didn't like me too much because we have to use a pipette type of no cartridge at that time. And for example, in this patient with severe traumatic injury, you have severe coagulopathy with a prolongation of the R, as you can see, of the R here. And then you have to correct it quickly with probably plasma or PCC, and you avoid to use other products that are really expensive. As a matter of confession, or as a matter of information to you, a blood product in Qatar is extremely expensive. 1 unit of PRBC is $1,000. 1 unit of fresh frozen plasma is $1,000. 1 pool of platelets is $1,000. When we activate the massive transfusion protocol, we spend $20,000. The first treatment is $20,000. So we're saving a lot for the patient with the complication that has been addressed to using a blood product here by the panelists. And also we save a lot of resources for our institution. And then we have, because we're in the middle of the night, everybody has a protocolized how to use the factors accomplished with those to try to address this coagulopathy. And this is, I think this is my incredible target right now. We use rapid INR. It's really in less than 1 minute. I have an INR of those patients. We use the Rotten Sigma, and I use the platelet mapping or the Tech 6S. And I give you this innovation in trauma management that has been changed for us. Severe traumatic brain injury, all the elderlies that you mentioned, they always have dual antiplatelets. They come to us, they fell down, they have like this patient I'm presenting to you, 70 years of age, you know, with a massive lesion, with bleeding and dual antiplatelets. You do the platelet mappings and you can correct the coagulopathy and avoid a death, a secure death in this patient. This is our protocol. We repeat it every half an hour, and then as you can see, is really in the column on the blue is our tech platelet mapping protocol for our patients that are, you know, we can provide to you or to your institution. So it's another innovation that we have studied is what is the prognosis on some severe traumatic brain injury that come to us. We address this issue with a extraordinary fibrinogen level, and we have a critical level 1.5 or 1. And after a study for 5 years, we noticed that increased exponential mortality rate if your fibrinogen on admission is less than 1.5. When you get to 1, you know, you increase mortality rate is probably 263%. And this study has demonstrated our association for serum fibrinogen levels and mortality, especially in blunt traumatic brain injury. What we bring us is to the next topic. One, we're going to establish resuscitation of those patients. And family issues for us is extremely important. Many of our co-workers doesn't have a family living in Qatar. And then that's what we have to address with psychologists, with case managing all of those patients. This is case number 2. It's a 60-year-old patient with a family, powerful socioeconomic thing. He had a GCSO3, he was rollover. Many of the patients doesn't use seat belt there. He came with a combination that is almost lethal. Severe traumatic brain injury, coagulopathy, and your lung that cannot be ventilated. So this patient was called the family, and they finally agreed with ECMO. We put ECMO in our hybrid OR where we can do CT scan, you see on the right side, and also we can do the ECMO at the same and see any other injury. Family agree, and because of the socio-economical issues, we have to have a bridge for sometimes for those respiratory failure. Or we do an INO treatment, or we do probably the ECMO at the end. We use VV ECMO, especially in patient that has traumatic brain injury. ECMO was run for 5 days. The patient was transferred to one of the rehabilitation center, and the patient was happy with the care. We have to be prepared with multiple cases of the incidents because many incidents can happen. You know, you saw the earthquake in Taiwan, could be a typhoon, could be a hurricane, and this is a hospital-wide requirement, and that's what we do in our hospital. Nobody knows CPR. First of all, it's 80 degrees in the summer, so that's why those patients come to you, and we have to be addressed to do these patients. Issues with technology, please maintain the compassion and the respect or the dignity for those patients. They are like us. They could be your brother. They could be your uncle. So it doesn't matter what is AI tell you, because all of our students just ask with the AI when you ask that question. Your human touch is the most important thing for us. And with this, I think it's important collaboration education is the best foundation. We have established with South America. I'd like to establish with Sri Lanka. We have an incredible facility all for you. And I will leave you this video of what we have produced. This is probably the most sophisticated simulation center that you'll see nowadays. It's the second largest in the world. And we provide the courses, a little bit of volume, please. We provide these courses for nurses, for anesthesiologists, and also for surgeons. This is a course designated for severe trauma patients with a lot of operative approach and a POCT, ultrasound use. The nurses take a big chunk of this incredible enterprise that I call it. Without the nurse, we cannot do it. And that's what I think. More complete course. In January, we established the Qatar Trauma Care Program. It's being approved by the WHO. It's the first course in trauma approved by the WHO for the Enroll region. We invite people from Sri Lanka to participate also. And since last year, Qatar has been established as a WHO collaboration center. One of the few in the world. We have with the nurses from the OR, with the nurses from the ICU, with the nurses from the A&E, called trauma resuscitation. All of them are really It's target basically with the armed conflict in February. That was Sudan, Iraq, Yemen, and Gaza. And has been really a great reward for all of us. In summary, it's important to understand that we have to embrace and hug all of this technology that come to us. But I warn you, you will avoid secondary insult. You will avoid burned out if you treat your patient with compassion. Because I think it's a recharging opportunity that we have, talented by God, Allah, or any religions that you believe, to really treat and serve the other one. This has been an incredible journey for me in Qatar for the last 15 years. We have incredible done this because Trauma Critical Fellowship, you have in the first row one of the recipient and an incredible star, and Dr. Faith Ahmad Ramsey from Sri Lanka is becoming a star. And it's really take a village, to do what we have done. It doesn't only take money. And I would like to invite you officially to the next Qatar Health Congress in 2026. It's going to be in November 12 to 14. It's a small country, but we're going to come big. Everybody should meet in Doha because we'll join the World Congress of Emergency Surgery and the World Congress for Trauma Simulation for the students at the same venue in Doha next year. And with that, Bohoma is tutti.